done so. Good evening to everyone. I think we have everyone now. We'll go ahead and get started. So good evening to everyone. Welcome to week 5. I know
Dr.
you all
Ford,
are down to the assignments and delegation part, but I'm gonna go back and recap just to make sure.
Dr. Ford, but
Mm-hmm.
Vanessa just telling me to let you know that she's not feeling well. She's in the bathroom. She'll be joining soon.
Okay, thank you for that information.
Okay.
So again, welcome to week 5. As always, these sessions are recorded and they're viewed by the attendance administrators. Ensure that your name and your campus is in the chat and that you have checked your screen name. Ensure that it matches the roster. I know you all are up to the assignment and delegation part, but I want to go back and just ensure the content that I've reviewed it. In the event that I lose connectivity, hopefully it doesn't happen. Hopefully the storm has passed over. But in the event that it does, just stay right there. I'll try to log back in. So you do know your exam is on next week. Make sure that you have your IDs. Let me go ahead and share my screen. You were given the blueprint. While it is just a few concepts, we know this communication piece is huge. There's so many moving parts to that. So care coordination, communication, leadership, and collaboration, those are the huge concepts. But under each of those concepts, especially communication, really all the others, the collaboration and leadership really fall back on this communication. You always have math. We place math questions and answers in the announcement section. So make sure that you're working through those. And let me stop sharing. So last week's content and this week's content is what will be on the exam. So make sure you review last week's recording and this week's recording. For those of you that are just coming in, ensure that you place your name and campus in the chat.
The evolution of nursing. Did we go over that?
Yes, we have.
Okay.
All righty, let me share my screen here and we'll roll right on. Okay. All right. Slideshow from the current slide. Okay. So as healthcare professionals, we're signing up to be life learners. So our education and things that we're learning is every 5 years, we have to get caught up on the latest evidence. So that ensures that we're competent. And examples of that is when we do our workplace evaluations, sometimes they do those every 3 months, 6 months, every year. All of those things shows that, hey, we're competent. And it also identifies things that we might need to work upon, work toward, or increase our knowledge about a concept or a skill. So competence should be continuously evaluated and improved to ensure high quality patient care is given. So if you've been a nurse 5, 10, 15 years, you want to be, one requirement for most states, pretty much all states, is a continuing education unit. Now the number varies. The number of these units vary. And what that is education, is information that you gather or obtain to improve your competence, to improve and strengthen your knowledge base. Okay. So care coordination, what is that? Care coordination is recognized as a professional standard and essential competency. It is fundamental in improving quality of care. So who would have thought coordinating that patient's care? The example that I always mostly give is the patient that's in the facility that needs physical therapy or occupational or speech therapy, but they also have an appointment. So we want the client to get the therapy and also return to that follow-up appointment or whatever that appointment is that they have. So we have to coordinate and think it through, think about the times. It's all about critical thinking and stepping back and looking at that big picture. It is fundamental in improving the quality of care delivery while reducing inappropriate use of healthcare services. Because what will happen is if that client or patient is not there for the physical therapy or the therapist to render their services, then in their documentation, they're going to, put refuse, and then they'll give an explanation. Patient is not available. And then if the patient doesn't go to their follow-up appointment, then they're going to be listed as a no-show. So what happens with that is that leads to underuse of healthcare services. And then in the end, it ends up leading to rehospitalization, readmissions. It leads to the patient not being able to manage or get to that optimal level of care. So care coordination organizes care and information around the patient's needs and their preferences. We do want to establish those therapeutic relationships early on so we can find out what do they value? What do they know about the disease process? It could be that they might not realize that they need this therapy, that they need this medication. But of course, we're going to support their autonomy. But we do need to identify what their preferences are. Care coordination is one of the 6 priorities. They're saying, hey, this is really priority in order to provide more affordable for this patient to have improved outcomes. So the Patient Protection and Affordable Care Act identifies care coordination as keys in shifting towards value-based care delivery models. Effective, the word being effective, care coordination, it helps prevent those fragmented services. Cost efficiencies. Because just think about this client has to keep going back to the hospital. This client's not getting the therapy they need. And they're not getting restored to their optimal level. What if this client was working on a job prior to the injury, the stroke, or whatever it was, and this client is not able to receive the therapy so that they can get back to the optimal level? This client is not able to follow up with the doctor like they should. What's going to happen? The client is going to lead to poor health outcomes. And then there's going to be an increased cost on the client. The client may need long-term care, may need some type of assistance. It is important for everyone, not just those with chronic conditions, but we kind of think about those with chronic conditions all the time. But it's important for everyone, as all individuals may need improved coordination at some point. If they're going from facility to facility, even if it's long-term care to long-term care, acute from the hospital to long-term care, from the hospital to home, those conversations need to be had about what this client needs, what they understand, what resources are available so that care is coordinated. So I said the other concepts really all go back to communication. Communications competence in nursing requires that communication be both effective and appropriate. Effective and appropriate. Effectiveness is achieved when the goals of the communication are met. We have a sender and a receiver. So we want to ensure as a receiver that the information that we receive is actually what the sender, person that we're in conversation with, the person that we're communicating with, is actually what they intended. So effectiveness is achieved when the goals of the communication are met. Appropriateness is achieved if the communication is well adapted to the people and the situations it involves. If the patient's primary language is German and I'm speaking to the person in Spanish, there's going to be ineffective communication. And in the event that I'm speaking to the patient in healthcare terms or in health as another healthcare provider rather than in layman's terms, the information that we're sending to the patient, the receiver, is not going to be received. Therefore, communication is going to be ineffective. So again, communication competence in nursing requires that communication be both effective and appropriate. So we talked about the different behavior styles. We said non-assertive, which is passive, and then aggressive and assertive. So which of these do we want to use as a healthcare provider? Which one of these is favorable? Which one should we use?
Assertive.
Assertive, yes. And we'll talk a little bit more about that in a couple of more slides. And of course, we're reviewing because we reviewed this information last week, but want to make sure we got it. Non-assertive. Fear-based, we're passing the buck. It's a way of being dishonest and really disrespectful in the event that we know something or have an answer to the question, even if we have the answer is, let me get my supervisor, let me get the dietitian back in, let me bring the doctor back. So non-assertive is not where we want to be. We want to be assertive. She was correct. So there are all different things that affect communication. Just think about if for the most part, facilities are trying to have like that one person in that room, but sometimes that doesn't happen. And then if you're going in and you are doing a head to toe assessment, the patient in the B bed, they might be in pain, they may be hollering out, they or they may be confused and they're trying to get up unassisted. They're making noises, different things are going on. They may dressing change may be taking place next behind on the other side of the room. And the patient that you're in the room with, bed A, you're talking to them and you're trying to gather information. That situation that's going on the other side can influence the information that you will receive from the sender. They may not be paying you attention. They may not really hear you. So there are different things that do affect communication, even personal space. We do want to, make sure that we're not in people's personal space, but close enough so that we're not violating privacy when we're talking to people. We may have to take them to a quiet area. But even if the room is cold and we're trying to go in and do a head to toe assessment, remove the covers and, you know, um, turning back their gown, all those things, that client might refuse, but they're not outright refusing, but the conditions, the situation isn't favorable for them to be uncovered. So, and then hence communication will be ineffective and it just will stop. So just think about that. There are different things. So you want to step back and make sure the room temperature is fine, make sure they're understanding what you're saying. Even the room, if there's an odor in the room. We talked about nonverbal and verbal communication. We do want to document both. We can also document whether or not these things actually are there. For example, no facial expressions, no facial grimacing, or patient has facial grimacing. Think about their body language. A person is guarding. We go to, listen to bowel sounds and they're guarding. Is this an indication that this client doesn't understand what we're getting ready to do? Or is this stomach having some abdominal pain or discomfort? They're fidgeting, they're yawning. We want to capture all that in our documentation. So we have some active listening techniques that helps us to be able to ensure that whatever the message is that's being sent is being received correctly. So restating, repeating what the client said in a slightly different way, clarifying, asking questions in response to the client's statement to be sure that we understand, reflecting, putting into words the information you receive from the client at an effective communication level, paraphrasing, expressing in our own words what you think the client needs. So all of these techniques, we're not changing what the person is actually saying, but we are just restating it in some type or rephrasing it in some form or fashion. So active listening also, this one right here, remaining silent, is one that we kind of have a problem with because we're trying to fix things and making sure things are okay. But as a nurse, sometimes we just being quiet, just letting that client exhale, say what they need to say. And sometimes they're quiet and we're quiet, just letting them know that you're there, for their best interest. And you understand that they need a moment. It is okay. So remaining silent is considered as active listening. So summarizing, so stating the main data from what you've gathered. So they give you this whole, scenario or a calculation of what they've actually thought was going on with them. So from that whole conversation, you pull out those main points, and then you ask the client to validate. Okay, these are the things I heard you say. I'm listing the top three. Correct any information if what I'm stating is incorrect. So that's that validate, because we want to make sure, because sometimes information gets mixed up. So we have open-ended versus closed-ended questions. Closed-ended is where we're going to get a specific answer. Yes, no. Open-ended, the client is able to, elaborate, give us more details. And then based on what they say, then we go into those focus questions. Because if we ask the closed-ended question, for example, are you in pain? And they say yes. So a more focused question would be like, where are you hurting at? Where's the pain? When did it start? Does anything make it get worse? Have you taken anything? So those focused questions allow us to get more definitive answers. And it takes us down that pathway. Whether or not it's pain, person said they started having shortness of breath. Well, when did it start? What were you doing? Have this happened before? So positive communication behaviors, um, things like using I statements, messages are actually positive. When we use those I statements, understand this to that you're saying whatever it is that you're saying, that is actually positive rather than saying, well, you said or you said. So I messages, establishing eye contact, not sustained or glaring at the person, but making that casual eye contact, look away, and then look back toward them. But these are all positive communications. We want to be aware of our body language and our posture, even our voice tone. You know, if the person's right there, should our tone be yelling or should our tone just be like a normal tone? It should be normal. We do want to make, like I said, make that eye contact, use open communication. And the whole idea is to establish that therapeutic relationship because we really do want to provide that best care for that client. So active listening, empathy, and developing trust will facilitate effective communication. If they know that you're there genuinely for them, they'll tell you about the good, the bad, and the ugly, in which we need all of that information to come up with clear care plan, a unique care plan for that client so that we can come up with interventions that are specific for them and provide being in the avenue of providing that best care for that client. So active listening, empathy, and developing trust will facilitate effective communication. Not that you are telling them wrong information, not that you're trying to bend rules for them, but you're just being open and honest about whatever it is that's going on. Okay. Assertive communication involves expressing ideas and opinions openly while remaining respectful to others. The client may be trying to tell you about whatever it is that they're trying to tell you about. We want to remain silent and listen to whatever it is that they're telling us. Use it even if the client is speaking in a tone that is aggressive, we can remove ourselves. We're going to talk about the chain of command here in a few. We may need to call our another team member in, our charge nurse or the ADON or the DON, which, depending on the facility that you're in, is the titles that they have. We just said using I statements to express one's thoughts, feelings, or needs clearly and directly. This approach allows for honest expression without blaming or attacking others. If we're saying I, it doesn't seem like we are blaming or attacking someone, which in effect promotes effective communication. So negative communication, the one that we pretty much get hung up on is this right here, giving advice. The other one's why questions, false reassurances. Are you going to be okay? We know not to do that. But this giving advice because we're genuine, we've established this therapeutic relationship with the client. And because you're that nurse, everybody's coming to the nurse. And that patient will say, well, nurse, what would you do? And they genuinely not trying to, it's not a trick or anything. They really do because they trust you. They want to know what you think. But we don't want to give them advice. We want to ensure that they make an informed decision. If we have to bring back the doctor, bring back the dietitian, or whatever the circumstance is, so that they can get more information, so that they can make that informed decision. This slide just shows, the communication. That's the different parts of it, the moving pieces. Patience.
I'm in class.
Honesty. Let me stop sharing for just a moment, you all. Remember we're recording. Okay. All right. All right. APR, the Institutes of Medicine, they've created this tool for us to use so that we can communicate effectively and so that we're not leaving out any information. So APR, what is the situation? Is it handoff or is it something going on with this client? Fever, complaint of pain. What is the reason that we're calling? What is that situation? We include our name, the unit, and the client name in the problem. Background, they need to know the admitting diagnosis, the date of admission, the current status of information. So we want to get them the latest vital signs. If we're calling the whomever at noon, we want to get them those vital signs that were closely obtained to that time. Usually we go ahead and get a new set of vital signs if something's going on with that client. What medications are they on? What allergies? Because if they're going to prescribe a medication, they need to know what their allergies are because we don't want them to prescribe something they're not supposed to be taking. their code status, IV fluids. So assessment, what do you think is going on based on the data findings? Because remember, we're spending most of the time with the clients anyway. We're there the 8-hour shift to 12-hour shift. So we're spending most of the time. So we can see those little changes and we can give that comparative data, that comparative assessment data. Well, I took care of this patient yesterday and I'm here back here today. You know, Yesterday they were alert oriented times two, person and purpose. Today, they're unsure of where they're at. They're not even responding to tactile or verbal stimuli when their name is called. And then recommendation. What is that? The goals of care. What needs to be done? And it might also include a consult. We might have to have that patient transferred to a different floor. If we're on med-surg, that client may need to be transferred to another facility and or to a different level of care within that same facility. Are we going to get new medication orders, new treatment orders? What do we recommend? Because you have that knowledge base. We've learned diagnosis, we've learned it on various lifespans. So we have information. So what are you? And plus, you have that history of working with that client. In addition to that, you probably have received report from another nurse. So you also have that information for comparative data. And this is just another way of looking at the SBAR. We do use it when we are doing a shift report. We're leaving and the next nurse is coming on. Some facilities have it where the information that we've inputted all shift, they have it flagged. So you can do this printout or this screen shows what this Cardex, whether that is an e-Cardex or printout Cardex, but it still has all of this information on there. So do consider when you're reading your scenarios, do consider who are you talking to? Are we talking to a school? Are we the school nurse? Or are we talking to an adult? We're at the industry working, we're the industry nurse. Is it an adolescent? Is it a toddler? So consider the age of the client. So when charting, we do want to always take the time to document. We want to make sure that we're actually documenting accurate factual information, not appears. So use those descriptive terms, be as descriptive as possible. What did you see? What did you hear? What did you feel? If there was an odor, round, red, use all those descriptive terms. And then be timely. Just be thorough and concise and clear and brief to the point. Do not use assumptions like it appears. Well, did the client state that they were in pain? What nonverbal information did you gather? Patient had facial grimace and they were moaning, they were crying, or they did not have any facial grimace and no moaning. So don't say appears in pain. Document what you actually observed, what verbal and nonverbal information that you receive. So aggressive, it violates the rights of others, is attack on a person rather than the behavior. And the body language, example, leaning forward with those glaring eyes, voice, in a raised tone. Not that you're just speaking so that someone can clearly hear you, but your voice is in an aggressive, loud tone. Conflict resolution, except conflict is a natural part of life. We talked about you being taking part of that ethics committee. If conflict cannot be resolved, it's always pushed to that ethics committee for resolution. Improved team member satisfaction is an advantage of interprofessional collaboration. So as a team member, you're going to feel better about coming to work because, hey, if something's going on with the team, the UAP, the physical therapist, they're going to let you know. It's not going to be a surprise. Enhanced communication among team members is also an advantage of interpersonal collaboration. Eventually, they'll know, well, hey, I need to go tell nurse, what's going on. And it also leads to increased patient satisfaction because it's like, okay, our focus is this patient. Even though we may have 18 other patients, that patient is going to feel like you've established that therapeutic relationship, you're communicating with them, whatever the results are, whatever the information is that you should be communicating, and they're going to feel better about the care that they're receiving, the informed decisions that they made. So we have improved team member satisfaction. We have enhanced communication amongst the team. And then we have increased patient satisfaction. And then I did mention to you all it depends on what facility you're in. That might be one of your tasks where you give those surveys. Sometimes those surveys are on paper, they may be electronically administered, but they do ask the patients, hey, how was your stay? How would you rate your care? How was the nurse that you had on this day and on this shift? How was the care that you received? How was the food? How was the temperature of the room? They ask all of those things. So assertive uses statements of facts, not judgments. Specifically state what actually happened. The patient, you know, um, asked, said that they were in pain. Did we ask those focus questions? They described the pain. They rated the pain as a 5 on the scale of 0 to 10. They said the pain was on the right upper quadrant. They said that, it feels better when, they lay on the opposite side or they get no relief. Another example of assertive is when we're giving instructions for, we're going to talk about delegation here. If we're delegating a task, example here, I have turn and reposition at least every 2 hours, but we want to add what those every 2 hours are, at 8 a.m., 10 a.m., or 4 p.m., 6 p.m. We want to make sure that we're specific in our information that we are actually conveying. Complete the dressing change every shift, or dressing change should be done once a day, whatever it is. So assertive is being clearly communicating, being honest. It does stand up for the rights of the nurse, the patient, without violating rights of others. The ethics committee, we just said if conflict isn't resolved, it's going to more than likely go to that ethics committee. And this is an additional task that you can take up on working in a facility as well. So once you get in, when you do your onboarding, you may want to ask, hey, what other committees can I serve on? But the ethics committee, it resolves all the conflict. And then they also will make recommendations about revising policies and procedures. So assertive communication is honest, taking a positive stand and being confident in your statement, speaking openly, not to violate the rights of others, maintaining privacy. We want to stand straight, face the person, and then, have that eye contact. We talked about the I statements. Using I statements to express one's thoughts, feelings, or needs clearly and directly. This approach allows for honest expression without blaming or attacking others, promoting effective interpersonal communication. I want to stop sharing, see if I have any questions in the chat so far. So far, no. Okay, we'll keep on moving. And as we're reviewing these concepts, if there's any one concept that you still kind of struggle with, put that at the top of your list to go back and make sure you spend more time with that concept. Assertive communication involves expressing ideas and opinions openly, remaining respectful to others, and then propose a discussion. Be open to discussion, showing confidence in one's ideas while remaining open to the team's input as well. So this slide is talking about in a leadership example. So, while we know what the rule is, still be open to having that discussion with others on the team, without being, dismissing what they're saying. The rule, the policy might not change, but let's still be open to their input. Okay, we just said uses statements of facts, not judgment. Another example, vital signs should be obtained daily, at 8 a.m. Measure the weight monthly. All right, now I need to hear from you. What should the nurse do? All right, so in the chat, need to have responses in the chat. So we want to show that you are contributing, participating. What should the nurse do? The first example, we have the nurse has administered an antihypertensive. After rechecking the blood pressure we'll say is abnormally high or low. It's either way. It's high or low. What should that nurse do? So in the chat, just put a statement. We'll give you a minute and a half to respond in the chat. Let me put my little timer on. So our scenario is we're trying to say what the nurse should do. They administered a blood pressure medication, an antihypertensive, and trying to get to the time. Okay, here's the time. So just give us an explanation, a minute and 30 seconds. What should that nurse do? They went back, they administered, they went back and rechecked the blood pressure. It's abnormally high or low. It is 80 over 60, or on the other side, it is, 190 over 110. Either way, it's abnormally high or low. It's just not, for example, 110 over 70. It's not like 140 over 76. It's really abnormally high or low. Okay, I'm gonna stop sharing so I can see what your responses are. What should the nurse do? You have a minute. So a few more seconds. Make sure you're responding in the chat. What should the nurse do? Okay. So for the most part, we're saying verify what those results are. Especially if we're using an automated cuff, we want to verify our findings because we're getting ready to report this information, right? And more than likely, that doctor's going to give us some next steps, some orders. So we want to make sure that the information we're given is actual correct. So verifying those orders, and we're going to notify that healthcare provider. Now, tell me, what do you think the nurse should do in the event that they've called that provider and there's no response? Oh, you all don't hear me. Yes, you do hear me. There's no response after, you've called. Look, our little timer is up. So we've notified the healthcare. We verified the results are correct, whatever those numbers are, and we have followed the appropriate method to contact the healthcare provider, whether it's paging them, whether it's sending them a message through the e-record. Sometimes you have to call a phone number, and they say, hey, they're gonna notify them, they're gonna call you back. The nurse has followed the proper chain, but there's no response in 30 minutes, 40 minutes. What should the nurse do? Yep. So we're bringing that chain of command in. That's right. We don't just document that information and say, oh, we tried to notify them and just keep on moseying. No, we find out who do we report it to. The depends on what facility, DON, ADON, charge nurse, team leader, or what have you. But yes, we do not just sit with that information. It is not acceptable just to say, well, we tried calling them and we didn't get a response. So yes, we want to follow that chain of command. So what should the nurse do if they receive a critical lab value, a critical x-ray report? And you can come off mute and share what should the nurse do. Should they just put it in their record and make note that they received that information?
They're gonna have to notify.
No, they need to notify someone. Provider.
All right. Here you saying notify that doctor. A lot of times, when they call the lawyer, when they look back through the records, what they often find is the nurse failed to notify. So they receive that information from the lab, radiologist, whoever was calling that information in. We can't just put that information in the chart because it's the word being critical, that the lab is abnormal. The x-ray report is abnormal. We must report that information to someone that can, immediately respond and give us our next steps. So we can't just file that information away in their record and document, yes, talk to, whoever in lab, receive results. So we must notify. Okay. So the patient earlier has a discussion. Here's another scenario. What should the nurse do? The patient earlier had a discussion with the dietitian and has changed her decision about what the nutrition intervention should be. But they're telling you, the nurse. What should that nurse do?
Verify that
Verify. Oh, go ahead, Kenyatta. My bad.
oh, I said verify that with the dietitian first.
Okay.
I mean, just to make sure, that it was with the dietitian and not the um dishwasher or something like that.
So the situation is the dietitian came in and they decided on what the next steps were. I can add a little bit more detail to it. The client wanted they were refusing meals. They see that the patient wasn't eating. When the dietitian came in, the dietitian, after talking to the client and doing an assessment, they realized that the food choices, the patient didn't like them. So that's why they were not eating their food. It wasn't that they were outright refusing, they just did not eat those food items. So the dietitian came up with an alternate menu for the patient. The menu items were served, and the patient says, "Hey, I changed my mind. I know I told that dietitian I like these items, but I just don't want these either." So should that nurse just keep that information and document it?
Uh,
Oh, this patient,
You go
we
back to
told her,
Go
Go
back to
back
the
and,
dietitian.
yeah, go back to the dietitian
go
and
back to
see
that
that.
dietitian. It's
Mm-hmm.
not enough for us to just say, "Hey, oh, they changed the diet for you. You made this decision. Oh, you just won't eat today." No, we go back to that dietitian. It would be the same thing if the patient had signed on a consent for a procedure. The next day, the patient says, "Hey, I think I changed my mind." If the patient was on the gurney going down to OR, we're in the elevator. Patient says, "Hey, y'all, I changed my mind." We would notify that physician. So good, good. Okay. So suspicion. Okay, here we go. This is another scenario. What should the nurse do? Suspicion. I think I know. I'm typing these things up. So two shouldn't be in there. Suspicion that the family member is taking the patient's medication. What should that nurse
call
do?
the police.
Huh?
It's according to where they at. I mean, if
Yeah,
they in a
I would
facility,
let the nurse
then
charge.
yeah,
you
report it to like the
know.
charge nurse or the DON.
Exactly. And then that person more than likely, and they do call the police sometimes. It depends on what's going on in facilities, you might have to notify the authorities. So yes, the whole point is we need to notify the next person. So going back to assertive again, assertive communication needs to follow the chain of command. There are some times we're gonna get to a slide where we bypass the chain of command, and it's only in certain instances. But assertive communication follows the chain of command. The client safety. Remember, client safety, you all. We want to be an advocate for that client. Safety, safety, safety. So assertive involves expressing ideas and opinions openly while remaining respectful to others. Aggressive involves expressing ideas and opinions while violating privacy and being disrespectful and rude. It's the opposite. Okay. Let's see, communication behaviors styles to discuss the chain of command. I gave you some examples, and you all were spot on. You already knew we need to follow that chain of command. But this is my question: are there any circumstances from which we deviate from following that chain of command? So yes or no, and then tell me if you say yes, what's an example?
So I'm gonna say yes, and isn't abuse one of those things?
Okay. So what do we do? We say yes, and then what do we do?
Abuse is we are supposed to report review. We are supposed to report abuse, period. It doesn't say that we have to go to the charge nurse, but I'm believing that you're gonna have to because you're the LPN. So you're probably
Mm-hmm.
gonna have to get somebody that's in bigger authority to actually step in and call or do whatever it is that needs to be done for the client or the patient.
You
Unless
got
it
it.
is the RN that doing the abuse,
Yeah.
and I guess we
Got
will
to
have
put
to go
something in
over. I don't know.
So the thing is, you're gonna report it to someone, whoever's that next
Yeah.
person. If the
Mm-hmm.
next person is the person that's doing it, you will go to that next person. So of
Okay.
course, we follow the chain of command unless there are emergency situations. And emergency situations could be that there's abuse. It could be that this client, we went in the room, the client doesn't have a pulse or respiration. We're gonna bypass. We're gonna be calling the healthcare provider. Emergency situations. So abuse, someone has had a major change in status. There is a threat to airway, breathing, and circulation. We're going to go ahead and call someone or notify someone that can immediately address what the issue is because it's an emergency or extreme situation. Okay. All righty. All right. So organizations want and need organizational growth. So they want you as the employee to share your concerns and your suggestions. They welcome your new ideas because they want to grow. They want everybody to want to be admitted to their facility or to come to their facility if they need whatever services that they provide. So organizations want and they need that organizational growth. Because think about it, if people are not coming to that facility, then they don't need us to work. They'll eventually go out of business because no one's coming there to receive the services that they are providing. So of course we go about it being appropriate about making our suggestions and letting them know what our new ideas and concerns are. Then we want to make sure that we're going to stay within our nurse state practice act with whatever those suggestions are. But they want that. They want your input. When conflict within the team or between the team and the patient or family members cannot be resolved, we just said this, that ethics committee is who is consulted and they do the mediation. They get all the information from patient family members. They go back to the facility's policies and procedures. They look at the Nurse State Practice Act. They look at, what's, happening in other facilities that's like theirs, just to ensure that their policies and procedures and things are lining up. So again, like I said, you might want to participate on that team or not. I don't know if they pay you any differently, but of course you can have it listed as something else that you have some expertise in. All right. So even though we have that nurse right there in the middle, and they're going to be coming to us, they is everybody, the physical therapist, the dietitian, the radiologist, the x-ray technician, all of them are just as important, even though everybody comes to us like we're the main person. But we work together to meet that common objective. Care coordination is recognized. We talked about it as recognized as a professional standard, and it is fundamental in improving quality of care delivery while decreasing or reducing inappropriate use of healthcare services. We talked about care coordination. It does organize care and information around the patient's needs and preferences. It does promote positive patient outcomes and restores that health, getting them back to their optimal level. We mentioned Henderson. So I'm going to go away from her slide. What is Henderson's two main things? We have all these theorists in nursing. Henderson, what is her two main things? One of those two topics. Either you're this or you're that. I'll give you a clue. Either you're well or you're what?
Well,
Sick,
it's
Yes.
clean and
Or
unclean.
sick or
ill.
well.
Yes. So Henderson, her main focus is illness and wellness. So if you're sick or well. And so that was her focus. And so that was what her theory was all about. Just making sure that whatever those interventions that we're doing, those care plans that we're writing up and everything, that we're considering the whole person, even in death. Making sure that we're preserving that person's dignity and we're making them as comfortable as possible. Some people are never pain free, but as comfortable as possible, we want to maintain that dignity for them, making sure that they're clean, their mouth care is done, that they're turned and repositioned, that the temperature of the room is good. But Henderson's focus is, are you sick or are you well? We talked about effective collaboration. It involves sharing observations and inviting input from other disciplines to optimize the client outcomes. Now, sometimes the therapist, the patient that go to the therapy room, we want to ask, well, hey, how did they do? We want to look at their notes because sometimes our patients will do or act differently when they're around the therapist or around, someone else. So we do want to talk with them to see how they are doing. And then, especially if they're refusing, we want to see what's really going on. So we have the nurse. We have a slide that looks at the task of the nurses. So we'll skip on over to the surgeon. What does the surgeon do?
You surgery.
Surgeries.
Do surgery. And what else?
Do
They just did
consults.
surgery.
Repair damage.
Okay. So they do surgery.
They
Using
get
all different
consent.
types of. Say that again.
They get consent.
Okay. They get this consent to do the surgery. What happens after surgery? More than likely, that patient's going to need what?
Reassessment.
Pain medication. So they're the ones that's going to be ordering that pain medication. They weren't already on pain medications. Usually after surgery, when people wake up, those nerve endings and things start waking up, they're going to need some pain medication. That is who orders that. So the dietitian, what do they focus on?
Nutrition.
Nutrition.
All things nutrition, whether or not that diet needs to be altered. Example, Puree, mechanical saw. Whether or not those liquids need to be thickened. Normally we drink thin liquids, but if a person has a swallowing problem, which one of these would identify that the patient
Speech
has a swallowing?
therapist.
Speech
Speech
therapy.
Okay. So if the speech therapist has identified this person has a swallowing problem and they make the recommendation that this person's liquids needs to be thickened to nectar consistency, the dietitian is going to be one that oversees that. The dietitian, if a person comes in and we identify they're losing weight, they're going to be the ones that look at the menu options and offer that alternate menu. What does the social worker and nurse case manager, what do they do?
Discharge.
Discharging and
They make
and
sure,
do any type of
Find resources for the patient.
yeah, accommodate the patient
Mm.
with any disparities.
Okay. Respiratory, what do they do?
Provide
respiratory.
breathing services.
Breathing.
All things breathing. Got it. Healthcare workers are the same discipline that work together to integrate care that will provide clients with all services. They need to maintain a safe, can't get away from safety, you all, safety, 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 quality, comprehensive healthcare. Each member of the healthcare team needs to have good communication skills. Each team member has to be able to anticipate problems. We've already learned body systems. We've learned the most common conditions with those body systems. A person has asthma. We're not saying this person's going to have an asthma attack. We're not saying that their O2 set is going to be low, but in the event that this person has trouble breathing, or the O2 set is low, we're going to actually, I might as well go back. This person has a diagnosis of asthma. We know that that's mostly affected the respiratory system. So our respiratory system is supposed to allow us to have gas exchange. If those lungs are not inflated and deflate like they're supposed to, this person's gas exchange is not happening like it should. So we're all the time being proactive and kind of thinking it through. We're hoping that nothing happens to the person and they don't have any exacerbations or any critical moments, but we need to always be critically thinking. So the registered nurse plan the care, coordinate all the activities of care, including those from the other healthcare team. Remember, I told you about the patient that needs the therapy, but they also need to go see the podiatrist or the urologist or whomever. The registered nurse provide care that requires more specialized knowledge and judgment, teach clients, families, and other members on the healthcare team, and we do advocate for the client. So the role of the LPN, of course, we stand within our scope of practice, provides those basic and provides care in basic and client situations on a general supervision of the nurse, the doctor, and all the other on the healthcare team. Primary responsibility in the care of vulnerable populations with chronic and stable conditions. So we're just going to give an example. Where the nurse, the RN is trying to delegate or assign, we just say, are trying to assign a team of patients for the LPN. Should the RN assign the LPN to have a patient that has asthma, but they just had an asthma attack on the previous shift? Or should the RN assign the LPN the patient in room 201 that has diabetes and they're getting routine insulin? Which one?
The one with the routine insulin.
Exactly, because the other patient is unstable, even though they're not having an asthma attack right then. They recently had an asthma attack. So yes. Okay, good. So as an LPN, we can be that charge nurse in that long-term care facility. Usually after 3 o'clock, we're it. LPN, we're in charge. All things, everybody coming to us for the, this guidance is what to do. If there's inclement weather, if there's a fire, someone's pulled the fire alarm, the patient status has changed. They're coming to us because we have that charge position. All right, so let's look at these carefully. Total patient care. It is what it is. Total patient. Clients need feeding, clients need bathing, the client needs medications, dressing changes, total patient care. Functional nursing, assigned to complete certain tasks rather than care for the specific patient to complete certain tasks. You'll kind of see that too with team nursing. So all of us are taking, for example, there are 3 nurses and we're taking care of the clients that's on hall 1. And we specifically nurse A gets this task, nurse B gets this task, and nurse C gets this task, with the understanding that we're all collaborating to provide all the care for the client, but specifically with those tasks. Usually you see that in like emergency situations where we're tasking out, because usually each nurse is assigned their, specific patient. Primary nursing assumes 24-hour responsibility for planning the care of one or more patients from admission to discharge. And we already talked about the case manager. Within a specified time frame, they use these pathways and they identify resources for discharge, whether or not it is, medical equipment, whether or not it is Meals on Wheels, and they have other names for food resources, dietary resources. There's just so many resources out there, but they help coordinate that so that client's care continues, so that client gets that continuity of care. I think we talked about that information already. Continuity of care. Here we go. Effective continuity of care. Just think about it. Continues. Care continues. It can significantly decrease the risk of hospitalizations, readmissions. And we want that. So we want to make sure that the client, once they're discharged, that all the resources have been identified that they're going to need to manage their care. Therapy, Meals on Wheels, medical equipment, whatever it is, so that this client doesn't have to come back to the hospital for the same thing. So the client does not have to come back because they were not equipped to manage or take care of themselves. So continuity of care, it ensures proper follow-up. Do they have to go back in 4 weeks, 6 weeks? Medication management. Do they understand that they need to take this medication twice a day before meals, hour sleep, and coordination between care providers? Patients are more likely to maintain their health and avoid complications, which can lead to rehospitalizations if we don't ensure that there's proper follow-up, understanding of our medication regimen, and that there's not coordination between the care providers. So this patient needs therapy. Therapy was never set up for them to get therapy. How's this client going to get their motion back, their mobility back? All right. Each member of the healthcare team, all of us are valuable. We have an equal importance to each other and to the clients to provide that best care, to communicate good, the bad, and the ugly, to understand where the licensed practical nurse fits in the healthcare team. We're right in the middle. Everybody's going to be coming to the nurse. Ineffective communication is the primary cause of sentinel events, making patient safety the primary objective of handoff communication. So ineffective communication leads to bad things happening to people. For example, a surgery done on the wrong patient, the wrong extremity amputated, the patient being given the wrong medication. Ineffective communication. So if we're getting handoff, you're going home, the next nurse is coming on. And if there's some information that's being communicated that you don't understand, let's stop. Hey, okay, what did you say? Let's rewind. Need some clarity. If we need to make that phone call, we need to bring that dietitian back in. We want to keep our patients safe as well as us, but we do want to prevent this patient from having a bad outcome. We don't want it to be that because we didn't communicate something as a reason why this client had this bad outcome. We mentioned the chain of command. This chart just shows, the nursing assistant, the nurses, and all the others on the healthcare team. But look, we're right in the middle, you all. Whoever owns the facilities and things like that. That's how this chart is showing us. So there are differences between leaders and management. So we have leaders, they're people-oriented. The manager, we're just focused on tasks. So it depends on what's going on in the situation. We have inclement weather. We're needing to pull people to safety. We have a fire alarm. We're trying to get people to safety. We're focused on that task, getting those people to safety. So, but then the leader is, people oriented. It may be where the leader will bring in and ask the staff, well, hey, we have this new equipment. No, we're getting ready to purchase new equipment. How do you feel? We have some equipment here for you to test out. Give us your feedback. And so those are just some examples of when we would, have our leader cap on versus our manager cap. Okay. So transformational leaders empowers others and sets visions. They want to see the team members grow. So they may encourage you to be on that ethics committee. They may encourage you to be on that public relation committee. So transformational leaders not only make ensure that the best care is given to our clients, that they get the optimal care that they are supposed to have, but it also wants the team members, the people that are providing that care, they want them to grow as well. If there's opportunities for certifications or opportunities to work on other committees, they encourage the team member to seek out those opportunities, gain that knowledge. So we have leadership styles. We have autocratic, specifically concerned with the task. Democratic, balance is concerned with the task and the employee. And then laissez-faire, they're disregarding what the task is altogether. They're just concerned with the employee. Okay, I think I have another one here. Yes, so autocratic does not share responsibility and authority with the employees. Emphasis is on the policies. Now, there are times when you have to be, like I say, emergency situations is what comes to mind, that you're just focused on. Okay, what is the policy when when there's a fire? What do we do? Laissez-faire. When I think about this, when there are celebrations and things at facilities, like now there's Nurses Week has just started. So happy Nurses Day to you all, soon to be nurses. Nurses Week rather, it's a whole week. The facilities will, they celebrate the nursing staff, they celebrate dietary and all of that, and they will let the employees decide what they want to do, what activities, what team building activities they want to do to celebrate. But laissez-faire is not good when we're talking about patient care. For example, if we're letting the employee decide whether or not they're going to go in and feed someone or not, and that person requires assistance with feeding. We talked about democratic, it shares the responsibility. Okay. We talked about the situation. Depends on what's going on. The patient, with this situational leadership, we were talking about a different situation. Let me read this slide. Involves varying your leadership style depending on the situation. That two examples I just gave back here. Depends on the situation. We're allowing the staff to decide which team building exercises they want to participate in. And we're encouraging that staff to grow. When we talk about transformational leadership, allowing that team member to decide, okay, we have these two committees. I strongly encourage you to, select one of them. The ethics committee is about this, the public relations committee is about that. And that's when we're allowing that, that patient, the team member to decide. Because right then the situation is, we're just encouraging growth. It's not that something's urgent going on and we need to be in a room taking care of a patient. So motivation, communication, problem solving, team building, and management of stress. Because remember, you all have more than likely, I think you all may have taken care of 3 or 4 patients, but once you get into these settings and it's you have whatever that team is, whatever that number is in that facility. So we have things that causes us to set personal goals and to reach those goals, things outside and inside. Okay. Going back to empowering, that transformational leader is going to empower the staff to participate in improving patient care. Well, hey, we're going to get new whatever equipment, try these out. What do you think is best? Or, just getting that input. Staff have reported that patient in room 201, they're refusing to eat. I noticed you're always marking down, you're documenting the patient eats at least 75% of their meals. Can you tell us, what is going on when you feed the patient? What happens? And the nurse might say, well, hey, I always start off with a story about whatever, because I know they like looking in their picture book or whatever. And then, I talk to them about their family members or, their childhood and, while I'm assisting feeding. But empowering staff to participate in improving patient care and creating work environments that foster professional practice is a key principle. If someone selects equipment that is hard to use, that is faulty, because that's just what they decided to, it's a different situation if we let the staff, hey, we have these 3 different devices. You all work with them and tell me what's your input. What you all tell us which one that we should select. That fosters, that empowers staff to feel like they matter. And believe it or not, the staff matters. Because remember, if the staff is not there to take care of the patient, who's going to take care of the patient? Is that facility going to be in business? Okay. All right. So this job dissatisfiers, going to work and that equipment not being there, that equipment not working, that equipment is being in need of repair, having unrealistic workloads. Now, some states you all have a nurse patient ratio, and some states have their ratio says whatever the facility deems safe. Okay. So there's really not a number, it's whatever that facility deems safe. So communication skills, we talked about verbal, nonverbal, written. Sometimes we have to communicate over the phone, but nevertheless, we want to use those active listening skills, being silent, restating, using those I messages. Okay. Team building, activating belief, self-talk about the situation, ABCD, ways of increasing our own self-awareness of irrational thinking. You know, dispute those irrational thoughts. If you're thinking something that you know is irrational, tell you, do some self-talk. This don't make any sense. This is irrational. So that's all this slide is trying to show you. How to create a less stressful work environment. Organize your shift because it's going to be you and however many patients you got to take care of. You're that leader. You got to delegate. You have to oversee. Everybody's coming to you. So think about how you can organize yourself, get things arranged. You want to create that calm environment. But most of all, we do want to treat everybody with respect. We want to be respected and we want to give respect to others. Okay, use problem solving steps. You want to collect data, define the problem, set the goal, select interventions, and evaluate the plan. A lot of times, you got to collect this data because a lot of times when people say the problem is really not the problem. So we do want to define that problem. Okay, I don't think we need to talk about that. Let's see. Okay, assignment versus delegation. I'm looking at my time here. We have about 10 more minutes and we'll let you all go. But of course, I will still record the rest of the information. But we've covered most of everything. I do encourage you to make sure you go back through our class recordings. You should have 2, last week and this week. Exam is next week. Be thinking about it. If you need that exam proctored, send that email to reach out and find a proctor. Remember that proctor has to be approved by your campus dean. In the email, include you, the proctor, the campus dean, myself, and Dean Brown in that email. And you and the proctor decide that approved proctor, you all decide the date and time. And then I'll communicate behind the scenes with that, whoever that approved proctor is, if that's something that you need. Make sure you have your IDs, make sure you have your 2 devices, your chargers, and I think that's pretty much all for exam. So we haven't taken our second break. So let me just make sure I'm looking at this time right. Okay. Yes. So you all can log off now, but I'll stay on because I want to make sure I cover all the rest of the material. But feel free to stay on if you like. But you are free to go. But you are not free to not go back through this recording and last week's recording. You must go back through both recordings, you all. All right. So assignment and delegation. A delegation, we transfer the responsibility for the performance of any activity for one individual to the other, while accountability for the outcome still remains with the nurse. Just because we're delegating our tasks does not alleviate us of that accountability. So we're going to talk more about delegation here. We have, just like we have medication rights of medication administration, we have rights of delegation. We'll talk about it here in a few. Where can I find information on delegation? The State Nurse Practice Act. Okay, some states don't allow delegation. Delegation is not required. So you just refer back to your State Nurse Practice Act. Even if you have that compact license, make sure that you're following, whichever state you're in, you're following those rules for that state. So always think about your Nurse Practice Act, the organization's rules and policies, which the organization's rules and policies should match the State Nurse Practice Act anyways. They shouldn't be asking you to do anything that's not on that State Nurse Practice Act, our lawful to-do list, the things that we can do lawful. And then we can get information also from our professional nursing organizations. They have the NALPN, the ANA, the NON, and all of these. We talked about those continuing education units earlier. These organizations, if you belong to them, you can get those continuing education units usually for a different discounted rate, which you're going to need those to maintain your license anyways. All right, I'm going to read through this. Delegation. The nurse is responsible for supervising the patient care to ensure it is completely delivered. When delegating tasks, the nurse must take into consideration the skills and competency of the team member. So, what is this saying? The UAP that you're delegating this task to, is this on their list of things that they can do? Is it in their scope of practice? Have they been checked off in this facility that says it's okay for them to complete this task? Okay. As well as the condition and the needs of the patient receiving care. Is this patient stable or unstable? So if we were trying to delegate mouth care, we were delegating a bath to a client that is unstable. Well, we know that the UAP can complete that. That's a task that they more than likely can complete because that's on that. We've checked their skills and competency list. Is there. They can do that in this facility. But the thing is, I said this client was unstable. So even though the UAP can do the mouth care, denture care, they can do a bath, if this client is unstable, we would not delegate that task to the UAP. Delegation of patient care tasks and other healthcare workers is one of the most important responsibilities. So the nurse is still responsible for supervising the patient care to ensure that competently care was given, that the correct care was given. So we go back to this right here. We must take in consideration the skills and competency of the team member. Can this UAP in this facility complete these tasks? Excuse me. Then we want to think about, is this client stable or unstable? Because even if it's a task that they can complete, we don't assign them. We can't delegate it if that client is unstable. So here we go. When we are deciding on delegation, we need to consider, is this the correct task? Is this task within this scope of practice? Is it in the guidelines? Can we delegate this task to this person? Is it the right circumstance? Is this client stable or unstable? The right person, decide who is qualified. Okay. And then we want to make sure that we're giving the right directions or instructions and making sure that we're communicating clearly. We want to give that clear explanation about the task. This patient should be turned and repositioned every 2 hours at 8 a.m., 10 a.m., or on every even hour. We want to be specific. Clarify the timeline and expectations with the delegatee. Right supervision and evaluation. Feedback to assess and improve the process. We want to evaluate the client outcomes. Okay. So why is delegating important? Increases your effectiveness and efficiency as the charge nurse. Instrumental in realizing client goals. May help nursing assistant increase and improve their job skills. It can add to and make sure like the skills that they have been checked up on. If you don't use those skills, they say you lose them. So these skills that they've been checked up on, it keeps them competent and short in their skills.
Can you go back to that other slide?
I got a question too, Miss Ford.
Thank you.
If you don't mind, Dr. Ford.
This is slide you're talking about?
Yeah, I just took a picture of it so I can go back and write some notes on.
I have a question, Dr.
Mm-hmm. I'm listening.
So, I know, like in other states as the LPN, you're not allowed to do certain things, but in like South Carolina is very limited. But if you go like New York, it's more open. So if we was to get our license here, but move to like California or something, the delegation still be there.
You went
If you
in and
get what I'm
out. I
saying.
think I heard you say, now correct me if I'm wrong. I said you were going in and out. It may be my connectivity. So some states you can do different things in certain states. It depends on what that state nurse practice act say that you can do. So if you decide to move to a different state, and if you want to practice in that state, you must have that license in that state. You follow whatever that state nurse practice act says. Even if you're in that compact, certain states have compact license where you subscribe and you pay that one fee. That one fee means that you're licensed in all these different states. But still, when you go to that state, you practice under that state nurse practice act. When you go to that state, even though it's a compact, and you didn't have to purchase individual license. So the compact alleviates you. For example, if you end up want to work in 10 states, the compact eliminates that nurse buying 10 different licenses. But it still means when the nurse goes to Alabama, they practice under the Alabama State Nurse Practice Act. When they go to California, and you have to be careful too, you have to be able to turn off if in that state, if it's not appropriate for you to do that activity or that task, you got to remember not to do it. Because otherwise you're practicing out of your scope of practice. And if something happens and they go all back to the facilities, policies, and procedures and that nurses state practice act, you'll be found negligent in providing care outside of your scope of practice. I
Okay,
think I heard you say that. Did I
that was
answer your
my
question?
yes, ma'am. That was my question.
So that compact just alleviates that person from having 10 different licenses. So that's why I always say that compact is good, but then you got to remember, okay, I'm in New York. I need to do what my New York State Practice Act says that I can do. When I go over here, I can't do when I travel to this state. I can't do certain things. You got to remember that. Yeah, that's what that means.
Thank you.
You're welcome. So legal aspects of delegation. Delegate only if allowed by your state's Nurse Practice Act and facility policies. Here it is right here. Only if it's allowed. You got to remember what state you're in and what's on that state's Nurse Practice Act. Determine stability of the client's conditions. Is client stable versus unstable? Delegate duties for which nursing assistants have demonstrated ability. Is it on their competency list? Is it on their checkoff list that says that this person can complete these tasks? If not, we can't delegate it to them. Provide specific, objective, clear-cut directions to the nursing assistant. Turn and reposition every 2 hours on the even hours, 8, 10, 12, and so forth. Measure blood pressure or vital signs once a shift on the last hour of the shift. Be specific as possible. Monitor the activities of the nursing assistants when they carry out the delegated duties. Depending on the nurse's assistant and the situation, this monitoring can mean anything from being right there to a periodic check. Just depends on what we're delegating. But remember, we're not relieved of ensuring that correct, safe care is being provided just because we delegated to someone. It still falls back on us to ensure that it's being done correctly. We need to intervene if correction is needed. If something is being done incorrectly, we have to intervene. On completion of the delegated duty, evaluate the safety. We keep talking about safety and effectiveness of the duties delegated to the nursing assistant. If you delegated improperly and a resident was harmed, it falls back on the nurse. They are liable. This could result in disciplinary action. It can result in civil lawsuit, nurse being sued, license being taken. You just never know. Depends on the situation. If you delegated properly, including monitoring, and that the client was injured, the nursing assistant is also liable. Delegation should always occur in collaboration with the RN. So we're making that decision together with the RN to delegate a task. According to the American Nurses Association, that was the ANA, the National Council of State Boards of Nursing, the RN should follow the 5 rights of delegation as well. The right task, let's go back to that slide where they're listed on there. Right task, circumstances, the correct person, the right directions or the correct information, the correct instructions, all that means the same thing. And then right supervision and evaluation. So the RN has to follow those same rights of delegation as well. So this is just looking at routine tasks that a unlicensed personnel or a CNA or a nursing assistant can complete. But remember the example that I gave you. Even if it's let's pick something on here. Measuring the client's vital signs. This client is unstable. We would not delegate this to the UAP. Even though this is something they can do. But the thing is, this client is unstable. Okay. So examples of duties not to delegate. Complex sterile technique procedures. Inserting a Foley catheter. dressing change, administer medication. These are things that we're not delegating. We're not going to delegate that. Okay. So the LPN, the first line leader, charge nurse, expanded role. That's an expanded, considered as an expanded role. So we're looking at, remember what that facility's mission and that vision statement, why are they there? What services are they supposed to be providing? And we're there helping that facility to fulfill their mission and their vision. You know, they're saying the facility is open because they're saying they're providing skilled care. Remember, we're providing those skills. We are doing the dressing changes, you know, and certain the Foley catheters, those are skills. This is just looking at the job description. So as that charge nurse, we can be a mentor, a preceptor for new employees. Okay. But it's going to be us to know all the conditions. If you're that charge nurse, you're responsible for everybody. So you got to know everything about all the residents and including the staff. Because remember, if you're delegating, it has to be on that person's skills list that so they can complete those tasks.
Dr. Ford,
Mm-hmm.
as an LPN charge nurse, can you be a DON?
I haven't seen that.
Okay.
I haven't seen it. What do I need to be in charge? What do I need to know? So again, all that facilities information, their all their policies, and you that if this is something that you decide to do as a nurse, they'll train you on that because they know that you're taking on a huge responsibility, is an expanded role, and you have to know all of those things. The employee manual, the time sheets. It's like, what? We gotta know. Yes. The proper uniform, because you're the one that's gonna provide that correction and that guidance. Hey, you know, you're out of uniform. You know, this is your break time. You know, they've established these are times that we need to take break because usually those break times are when less patient care needs to be done. So it's important that we adhere. And you're going to oversee people adhering to that. And you provide that correction or that reminding if they're not adhering to what the facility's policies and procedures are. You know, you have to know what that mid process is, the discharge process. You know, what do we do? Do we have side rails? I've been in facility here lately. They don't have side rails at all in the facility. So, but they have like devices. I kind of think of them like those bean babies that they have that real soft little mesh stuff in them. They have those devices that they'll have beside people. But I've been in, they don't have side rails. You know, when do we lock the doors? We have to know when doors are locked, when a door is unlocked. So as that charge nurse, this is not to make you afraid, but it's just saying, hey, this is an expanded role, and essentially you have to know everything about the patients, the staff, the facility, and all of that. Okay. Medications, how are we reordering medications? What happens if it's after business hours? How are we getting this new medication in? How, if the patient has run out of medication, how do we reorder? Is there an on-call pharmacist? What is that procedure? Okay. So as that charge nurse, you're going to probably be the one that's going to be training people. So what is that facility's policy on, you know, training new staff? Again, it's not anything to be afraid of, but just know that it is, when they say expanded role, is a huge undertaking. But, you know, you can do it. And then we have to think about the family. We want to make sure that we're providing the best care we can to our clients.
Professor,
Mhm.
for some of the math problem that we had on the test, that's basically what some of the problems we're gonna have on this one, or it's gonna be different.
Oh, I don't know. I just know that you talking about the samples that we got. We just know that you have to know the basic math calculations and
Oh, I thought you went back and looked at the test.
but I didn't look at it in that realm. It's like
Oh, okay,
identifying, you know, what the math problems were. You know, we just look at the information to make sure the things are keyed correctly.
oh, okay, okay.
Mm-hmm. Yeah. So you do need to know the basic operations to do conversions and to do math.
Oh,
So
okay.
go back to your announcement section. We put sample math problems in there. Then we don't put the answers with that when we post the answers later on. We're going to give you time to work through them. Okay, so you got to deal with the family as the charge nurse. Like they come to you, they're going to be talking to you. You have to provide that reinforce that education. But we do want to be clear when we're talking to them. We don't want to make assumptions and give false reassurances. If we need to bring in the the healthcare provider, the dietitian, we bring those people in to talk to them because we don't want to give them information that we're not qualified to give and or that we're just guessing on. Okay. Each member of the healthcare team must have good communication skills. Each team member has to be able to anticipate problems to avoid them when possible. You got the patient in 201, they have a history of asthma, they're diabetic, they didn't eat their lunch, so we got to kind of think forward. Okay, this person didn't eat lunch. We probably need to be offering them an alternate, offering them a snack, because more than likely, if they've taken their insulin or whatever their medication is, that sugar's going to drop. So we have to be critically thinking at all times. Effective collaboration involves sharing observations and inviting input from other disciplines to optimize the client outcomes. That's just saying that we need to be communicating, collaborating with everybody. Like the example that I gave, the patient, we talked to the physical therapist, hey, what are they doing? I see that they're refusing. I see that they only stay with you half the time. Tell me about what's going on in the therapy room when they come down. Okay, so that was everything. I went back to last week and this week. Be sure to review this week's recording and last week's recording. We are providing you exam review links in the announcement sections. We're providing you sample math problems in the announcement section. So make sure you take your time back to work your way through those. You all take care, and we'll see you on next week.
Thank you.
You're welcome. Miss Burns, it's like your connectivity has stopped or something. Miss Bale, do you have questions?